Hey, 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 we're here. Episode 3. What do you think, guys? Episode 3. We made it to episode 3.
It's shocking.
We've made it, but I don't think we're going to make it much further than this if that's how you do the intro.
But why not?
He said, hey, it's Bad Albert. Remember that from way back in the day?
It was good. It was great. It was great. And I think you should just play it up because now you're going to be the designated intro guy for the rest of these podcasts as far as they go.
So what are we talking about? We're talking about fear tonight, aren't we?
That's right. I mean, as I said, a little bit of a pucker effect, if you will, considering kind of where we are and all that we're doing here. But in truth, we spend a ton of time, whether it be in undergrad, med school, internship, residency, fellowship, and then in practice, really trying to understand our surgical craft. In fact, I saw a provider in my clinic today coming in for a surgical consultation who, believe it or not, did my appendectomy 40 some odd years ago.
Wow.
And he and I were talking. Yeah, right. I mean, amazing in a lot of ways. And he and I were talking about, his bedside manner. I remembered a few things about how he came into the room and he had his hands in his pockets. And, I had my shirt up, a little bit anxious and fearful. And he puts his warm hand on my abdomen. You're a kid. That stuff gets really, really scary. And in the midst of all, he said, I remember that. I used to keep my hands in my pockets to keep my hands warm. Because it is very scary when you are coming in and talking about surgery. And these are the things that, maybe you don't learn in training, your formal training. You're going to learn when you're engaging patients. And so these are things that are a big deal to everyone, but it's not something that we openly discuss. So I think these are things that, this is an opportunity for us to kind of break this down. Let's kind of take it from the top. Fear, is it, normal? Is this something that we all deal with?
Absolutely. I think there's always fear in anything we're doing. And we need to get over that fear and, learn about things and be more confident about things. And this is true, not just for surgical procedures necessarily, but I think there's fear, like I have some fear in my kids going off to college, and that sort of thing. And so we have to get comfortable with these things and be like, this is safe for him to go to college, and it's a good opportunity for him to go off and be 3 hours away from me. And we've raised him for the last 18 years, and now he's going to be off on his own. He's going to do amazingly well because we grow them to be independent. And not to sidetrack, from what we're talking about today, but I think fear permeates our lives in many different areas, and we learn to get through it, I think, by gaining confidence through education.
Or taking anti-anxiety medication, which since we live in the area that we live in, we all see it as our patients. Most of our patients are on these meds. So I think, anxiety is really pervasive in our society. I don't know if social media and the internet and whatnot has made it worse. My guess is it has, just anxiety in general. From all the connectedness and the lack of almost familial connections that used to be generations before us. So I think that there's a ton of anxiety out there, and the anxiety that we see as surgeons, refractive surgeons, is some of the highest anxiety, I think, and some of the anxiety that is out there we never see. Because those folks never come to us, right? They want the procedure, they want to fix their eyesight, but they're paralyzed. So I think we should try to talk about, is this normal? How do we handle this? How do you handle a really anxious patient? Let's get into that a little bit. I think fear of the procedure is totally rational. And it's an emotional response. This is my eyes. You hear that all the time. These are my eyes. So I wouldn't do anything to my eyes. They're my eyes. But how do we each handle this? And is there a way that we can message people to connect with them so that not paralyzed with fear before coming in.
So you touched on 2 points, Andy. Your comment would be the majority of the individuals that have anxiety or are concerned about a surgical procedure, they don't make it in. And then we're talking about the individual across from us. And so to that end, these are potential candidates who have already taken that leap to say, we're going to not only schedule a consultation, we're going to come in and be evaluated, and we're going to sit across from a surgeon who's going to tell us what it is that they do and why this would be the appropriate procedure, in this case, refractive surgical encounter for them at this point. But let's back up. So you have now a broader audience with all the social media and the ability to have access to individuals far beyond your office and your consultative space. What are those concerns? Let's talk about what those anxieties or hangups are. Just go from there. Where do you go?
Okay, Sonny, what do you say?
Well, the first thing patients have the anxiety about is, being near their eyes, touching their eyes. I'm a blinker, I'm a squeezer. How am I going to get through this, right? And so some of the discussion just goes about, how we use verbal anesthesia to kind of calm their nerves. We offer Valium as well. I don't know if you guys do that, but we do offer some anxiety medicine, medicine to help them get through, anti-anxiety medicine to help them get through the procedure. But I think that because we all have such tremendous experience in what we're doing, we know how to connect with the patient and have that emotional intelligence on who needs what at what time to kind of get them through it. And I tend to bring the temperature down in the room with my temperature down, meaning my voice. I talk slower, I talk lower, I bring the temperature in the room down, and that helps them to kind of get through it faster. And what's interesting in the laser vision correction space with LASIK, because it's such a fast procedure and they come in with such high anxiety, by the time they get done with the procedure, they're just amazed at how fast it is. And that's one of the first things we talk to them about is, you may think it's a 30 or 40 or 50-minute procedure. It's literally 10 minutes. And so we're in and out of the room in about 10 minutes. That's one aspect of it. But I think if I take a step back, I think a lot of it is helping the patient understand that, for me anyway, it's a privilege when patients let me operate on them and do something for them to help them. And so I need to gain their trust, right? So when we're sitting with that patient in the exam lane, asking them the questions about, what their concerns are about anything, whether it's procedure or anxiety, and being able to answer those questions in a coherent, responsible way where they feel confidence in what we're offering. And I think once they have that confidence in what we're offering them, that helps them to kind of continue along the journey and then have something done. If we don't hit that off in the right foot in the exam lane, then it doesn't matter what we say to them. I think that anxiety remains, and then they're not going to have anything done.
Yeah. I mean, there's a lot of myths out there about refractive surgery. Actually, I think trying to bust those myths is really quite hard. Through social media, sometimes posts and things like that. I mean, I just did a post on Instagram because, we hear this all the time. Like, how am I going to hold my eyes open? The post was basically like, by the way, guys, you don't need to hold your eyes open. I mean, there's a little something that holds your lids open. And, even if you blink, it's not going to be a problem. The majority of people don't even understand that. Like they actually think that they're going to have to keep their eyes open during some kind of a procedure. So something just as simple as, how am I going to keep my eyes open? They think it hurts. They think it's going to, it's going to take weeks of time to heal. They think it only lasts for 10 years. Okay. For some reason, there's that myth. They think there's other things like, astigmatism, we can't treat astigmatism. They think they could go blind. All of those things that are out there are really hurting the industry in such a way that, all these people that want and can benefit from vision correction don't even come in. And so, yes, there's two parts. Like, how do we reach those folks, which is, I think, very hard to do. I really do. I mean, and then the second thing is, how do we handle them when they finally come in, right? And John, I don't know about you, but I try to set up the system in the office. You know this very, in a very calming manner. I think the way the office looks, the way the people talk. I see you smiling, but you know, I might not be the most calm guy out there in the world, but on surgery days, people can't. I'm incredibly calm. I lower my temperature. I'm incredibly slow. I also, I connect in a way that what you do is you bring confidence into the room. I think confidence and education, okay, both of those things break down fear. That would be something that I would say.
Confidence, education. Sonny brought up, speaks slowly, quietly. And you don't have to worry too much about this, Sonny. You got to make sure that you're below the height of your patient when you come in so that you're not intimidating.
Thank you for that.
Yeah. No, I get it. Andy and I may have a little bit more of a problem with that at this point. Again, it's just the height differential. I speak quickly. Andy cannot speak softly, even if he tried. I mean, whispering sweet nothings is never going to happen from Andy Holzman.
No. Well, I'm not coddling anybody. Okay.
Well, and so to that point, what I was getting at is you said it. There's confidence that comes through education and experience, and I think empathy. I mean, it's going through enough of these cases, seeing enough cases where it's not just the good ones, but some of the challenging ones, like things that don't necessarily go absolutely perfect, and bringing them around. Fortunately, I used to say, to some patients, anybody who's told you they've never had a complication has only done one case, or they're just flat out lying to you. And you need to be able to read body language. I mean, that's another big part of it. Understand from where a patient is coming. I think that's a big portion of being able to relate to a patient, be able to break down those walls.
Do you guys do your own consults? So for instance, patient comes in, they're thinking about it. In my office, they'll meet an optometrist, my technicians, and then sometimes me, but most likely not. And then they meet the counselor. So, I rely on staffing and the counselor to, somewhat speak with confidence and break down the fear so that the patient goes ahead and books the procedure. Do you guys have a similar setup?
I do. I'm much like you, where I might see an occasional consult, but I'm kind of like the clown at the end of the circus, where they've gone through the ticket, a person to buy their tickets, they get to the circus tent, they've watched the show, meaning they've seen my optometrist and my staff and the counselor, they've got all the testing done, and then I come in at the end. And I make sure I've answered all their questions. And, luckily, hopefully, we're all on message. We're all saying the same things. So otherwise, it can be confusing to patients. But if I can just jump back to what Jonathan was saying a moment ago, I have residents come and watch me do surgery from 3 programs now: Howard University, University of Maryland, and Sinai Kennedy Krieger. And when the residents come in, I take some time to tell them what I'm doing. I say, listen, when I go in the room, my energy level completely changes than when I'm talking to you here. And you're going to notice that I'm going to get in the chair and adjust my height to be at the level or just below, to Jonathan's point. And then I cross my legs. And I do that on purpose so that they know I'm not rushing. Doesn't matter what kind of madness and mayhem is going on outside that door. I want them to know and feel that they have my undivided attention, and I'm right there present for them. At a slightly below eye level, so I'm not in that that subservient kind of mode where I'm above them. And then I'm not talking fast, because then I think it can turn patients off. Then they can get anxiety just from my fast talking, and I think that makes a difference. And so they don't get that and I tell them, if you're seeing a patient in your residency clinic and you're standing at the desk and asking them questions, it's a much different experience for the patient, as it would be for you as a patient, than if the doctor sat down across from you. Do you guys agree with that?
Yeah, 100%. I'm always all kidding aside, I am much calmer and slower when I'm talking with a patient pre-op, and I'm going through my whole, thing. It's a lot of it is reading body language, and you can tell right away whether this patient's going to be, super easy, or if this patient is in complete denial. Some of them, they're not, they're like, yeah, 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 yeah. They're just listening to you, but they're not really listening. So there's all these different kinds of patients that we've encountered every day. And, I'm sure that we're all the same. Like, we can read that quickly, and then we might have to take a little bit more time with the really nervous patient. I give Xanax, not Valium, to 99% of people, unless the patient says, no, I don't want it. And the main reason is, honestly, it's not so much the surgery, although it really helps, I think, to kind of calm their nerves. Because I think Valium's a little loopier for the patient. Xanax is a little bit more just sort of mild, but it helps them sleep afterwards. So, if somebody says to me, well, I don't know, I don't want to lose control. I've never taken anything like that. I'm usually like, well, you're not going to lose control. Okay. I'm going to be talking to you the whole time. I'm playing music, in the background. I'm coaching you verbally. You're not going to have any loss of control. The Xanax is just going to help you sleep later, which is really important now. So I don't really give them too many choices. I know on that. I just kind of straightforward tell them sort of how it's going to go, and they're like, thank you. Yes, I'm going to do that. I don't know, John, what's your approach?
Well, first of all, I heard the mascot in the back. I assume that's Charlie making all that noise at your house. Is it not?
You heard that?
Yeah, we all heard it.
Yeah.
We all heard it.
Yeah.
Here's
I have a visiting dog. It wasn't Charlie.
That's not. I was about
my
to
daughter's
say.
Cavalier or something.
Well, I was
That's
about to say, poor
little dog.
Charlie looked like he's under a little pressure there.
No.
You get a little. I don't know. Something's not right with Charlie. But to that end, Charlie makes a visit to the office, doesn't he?
Yes.
Does he help? Do you find that he is a what do they call it these days now?
Therapy animal.
Therapy animal. Yeah, right.
Dog. Oh,
yeah,
100%.
Right.
When patients see that the golden retriever, it just completely eliminates anxiety. And everybody says the dog is better than anything else. So if you could have the dog at the office that's true. If you could have the dog at the office every day, it would be fantastic. But
yeah.
I thought that was a therapy animal for Andy. I didn't know it was for his patients.
It's everybody. It's everybody when it's in the office. But it actually it's a great touch. I mean, I got to say, everything that you've already talked about here are incremental benefits to the patient experience, which ultimately leads to a better outcome. We would agree with that.
It's all about patient outcomes. That's it.
Yeah. So, I'm sitting here. We had our fellowship is coming to an end for the year. Our fellow yesterday did a complete refractive case, start to finish, LASIK, everything looked beautiful. Patient's 2015 today. I was happy to report to the fellow the outcomes. And I'm sitting here thinking about it. We spent a year to set him off to then go out and do the surgical process. But I'm going to get back to this. The interesting aspects of it is he knows where to put his hands. He knows where instruments should go. But one of the things that was fairly evident still is communicating with the patient during the surgical process. The technical parts are fantastic. It's it's getting to that next step where you can comfortably relay to the patient what is happening with confidence and bring that level of anxiety down. I think that's what we've been talking about, right? That's it.
Yep. That's
yes. It. And that comes with experience and time and cases and holding patients' hands and dealing with different types of patients, to Andy's point earlier. And it doesn't come in just a 1-year fellowship. So he'll get there.
Yeah. Yeah. And so you or Andy had mentioned this. So there's a lot of, misinformation that then gets out there that I think takes hold, prevents patients from even making it into even explore options. Had a patient come in today, -10, was a outstanding, Evo toric candidate, implantable lens, phakic lens, or implantable contact lens for the the lay individual looking at this. It's a biocompatible contact lens, great candidate, right? But she said, I didn't even know this was available. My doctor told me it wouldn't be worth even exploring refractive options. And quite honestly, I was just too afraid. So could break that down one at a time. I mean, I think in large part, the information that she's received over the past 10, 15 years has created some anxiety. She still was motivated enough to come in, but it's misinformation. It's then kind of it's elevated by some of the practitioners, unfortunately, I think, that don't have a good clear sense of refractive options. And then it just cuts it right off as far as options for somebody who is very motivated to do something. So break that down. Tell me, how are you going to go about educating and breaking down misinformation and fear?
This happens not too infrequently, right, Jonathan and Andy? Patients are telling us all the time, my eye doctor said my astigmatism is too much or too high, or I'm too nearsighted, or I'm too this, or I'm too that to qualify for anything refractive surgery wise. But they're so interested that they come in for the consultation. And then when we tell them that they qualify for something, what's interesting is that their first instinct is to be angry or mad at their previous eye doctor who tried to tell them they weren't a candidate for anything. And I try to tell them it's not that they were lying to you, it's more because they didn't do the testing that we do to see if you qualify for anything. They're a different kind of eye doctor, whether it's an optometrist or ophthalmologist. I'm not pointing anyone out. It's just that they were not giving full information about what they qualify for, whether it is a laser procedure or EVO ICL. And then I go through and show them confidently why I believe that they're a candidate for what I'm offering them. And break it down for them, and then ask along the way, what questions do you have? And I tell them in advance, you can be drinking from a fire hose with all this information, which you certainly cannot process in one visit with me. So go home, do some research, go to the EVO ICL website, learn about it, watch some videos, and call me when you're ready to talk about it, or come back in and see me, and we'll talk about it together. Because invariably they've worn their contact lenses for their exams. They have to come back anyway for retesting. So we can bring them in for retesting and to talk about it all at the same time. And that's actually quite helpful. But that's been my approach. I don't know what you guys do.
Break it down. I mean, I'll ask, just go honestly one at a time for some of these fears. So someone comes in and says, well, the potential for vision loss, is high for one of these surgical procedures, right? I mean, there are challenges with that. And they're coming in wearing their contacts. How do you respond to that, Dr. Holzman? What do you say?
Well, I try to, present some facts. I mean, the fact is that I think it is the safest elective procedure there is. We operate, I'm sure you guys do too, on professional athletes and, military pilots, et cetera. And it's not a bad thing to occasionally mention that to patients that, it's normal to have fear, but let me educate you about this. The procedure's quick. You're in good hands. The technology is the best that there is. One of the key things I think that really helps people to calm down is when I tell them that we don't operate on everybody. Okay. Like I turn away 20% of the people we see. So I'm not here to do your case to just make money. Okay. I don't, thank God I don't really need your case. Okay. I'd be happy to do your case. Right. But if you're an excellent candidate. And so there's this process you're going to go through, and every single thing is going to have to be perfect. And you're going to have to be an excellent candidate in order for us to do this. And we are going to make sure that that you have an outstanding outcome. If you're an excellent candidate, you're in good hands, you're being treated with the right technology, the chance of you, seeing 20/20 or better is probably 98 to 99%. The chance of you losing eyesight is probably, it's not even a tenth of a percentage point, right? It's not
Very
even
low.
a tenth of
And there are risks with contact lenses too, which we haven't even touched on. Risk of infection and other issues that can occur from mishandling or miswearing your contacts over time.
So that is one that comes up routinely. That is an issue that it's in the literature. It is, it is a well-performed peer review article. Why is it that doesn't take hold? How is it that information isn't getting out there?
I don't think that patients, obviously haven't seen the study, but they just inherently think that putting contact lenses in is safer than having a quick 10-minute LASIK procedure. Putting contact lenses in every day for 20 or 30 years is somehow safer than having a LASIK procedure, which is not the case in good candidates, as Andy mentioned, right? And you're a good candidate for surgery, you're a good candidate. There are bad candidates, and we turn them away. Irregular topographies, keratoconics, other things. And so, when you're looking at, what makes a bad candidate, thin corneas, extreme dry eyes, uncontrolled dry eyes, thinning of the cornea like keratoconus or ectasia, things like that make patients a bad candidate for laser vision correction. There are other things you can do, and I know you do these. You guys can do corneal cross-linking in some of these patients. So there is something we can do for them, even if they come in for one thing, maybe there's something else we can offer them. But I think some of that fear about what if I make the wrong choice? What if I, am I going to regret having this done? What should I do or shouldn't do? There's always a choice.
Yeah. To me, I think it's all about confidence and portraying a lot of confidence when you're talking to the patient, and for me, I think honestly, I'm not, I don't know, I'm not patting myself on the back, but the confidence part comes fairly naturally. So I just go in and just sort of be myself and explain that everything's going to be fine, and I'm going to take good care of the patient. And, you're a great candidate. You really have nothing to worry about. I'm going to be talking you through this. We play good music in the background. You're going to hold a stuffy, okay, or a little football with your logo of your college on it, okay. So things of that nature, like, we're going to get you through this. And I also say, look, everybody's afraid. Every single patient's afraid, but all the same thing. Every time they're done, they say the same thing. That was so easy. I'm so glad I did it. I should have done it sooner. So we're all in this same boat. We want to be able to help more people. We want to be able to get the word out somehow that these procedures are safe, effective when done on the right people. It's just, I'm sort of at wit's end on how to reach more folks. Like, the optometrists that we work with, they're on the front line with these patients. And, so they're the ones that, are probably talking to patients about this or not talking to patients about this, right. more than ophthalmologists, quite honestly, because ophthalmologists, they're more in tune with specialty care, potentially, glaucoma testing and not so much refractive eye care. I think the optometrists are the ones that are on the front line with refractive eye care. So I do my part as best I can to educate the optometrists and make sure that they understand what their role is, and they understand how safe it is, and they know the risks and benefits. But the sad fact is that some optometrists still say things that make no sense to me occasionally. Like you shouldn't do this because you're going to need readers. Okay. I don't know. I'm an emmetrope. Okay. I've never worn glasses in my life. Okay. Yep. Okay. So what I say to people is, this is going to make your eyes normal for your age. So I can't make you 26 again, but you're going to be a normal 41-year-old. Mm-hmm. Okay. Normal. That's great. You're not normal now. Okay. You can't see at distance. What I'm going to do is make it so you can see at distance, which is totally normal. It's the normal state. And a normal 41-year-old, hey man, you need to put on some readers. It's not the end of the world. They're over the counter things. They're cheap. I mean, you guys know the same drill. We have to just keep working on the optometrist, keep working on our messaging on social media, and trying to educate. I think education is the way to sort of fight fear with really good education.
So you said you're at wit's end, and all three of us, have treated family members. We believe in, and Sonny, you've had it performed. I will take exception with this idea that you will be a normal 41-year-old. No, in many regards, normality is myopia in a lot of the population to some degree. Low degrees of myopia. There's a lot of myopia out there. And I would say normal and not normal. The point is, I think you have the ability to elevate vision. And I think that really should be our conversation. You're going to elevate vision, which is happening with refractive surgery, bringing people to 2015 and 2010. Supervision is becoming very close to normal with vision correction. I remember a time when I could count the number of individuals coming in that read the 2010 line with a virgin eye on one hand, but you'd see them routinely with people who had refractive surgery. That was something that was really impressive. And that number has only increased with the newer technology. I mean, you're seeing more of this supervision. So I would say what is being provided by you, Sonny, by you, Andy, and what we do in our clinics is actually beyond normal. It is better than normal. One question to both of you: is it generational? Do you think those who had refractive surgery 15 years ago, 20 years ago, is different from those who would be candidates for refractive surgery now? Is there a fear that just comes with the millennials and the Gen Alpha and I hope I'm even saying it
Gen
right.
Z.
Yeah,
Gen
come
Z.
on now. So talk to me about that. What's that all about?
If you in today's environment, I think what's happening is because of the way the economy is running, and you guys have all heard about the K-curve economy, and then the recent report a couple weeks ago, like 90% of the U.S. wealth is owned by 45-year-olds and greater in age. Own 90% of the wealth in the United States. I don't know if you guys heard that. So if that group is at the top of the K-curve, right? Economically in today's environment, and they're running in the presbyopic era of their lives, I think we're seeing an uptick in our refractive lens exchange. Patients choosing RLE over laser vision correction because, to Andy's point, they want to get out of reading glasses at the same time they're getting out of their distance glasses. That's not everybody, certainly. And so we presented to patients who are 45, 44 coming in for laser vision correction and saying, hey, you're a great candidate for laser eye surgery. We can do LASIK for you. You need reading glasses. This is the price point. We have a lens-based procedure to give it a distance and near, and this is the price point. Which is really what's like, if you basically raise your hand to come in and say, I have a problem. Help me understand what your problem is. Do you want to do A, LASIK and more readers, or B, a lens and try to minimize your overall dependence on glasses? And then I just stop talking and let them kind of process it and make a decision about what their true pain is, if you will. And then I let them answer, and then that answer then helps me to understand how to then walk them through their options one way or the other. I forgot the question was. I think it was, like Gen Z or Gen X, or what's happening. I think that I think the younger generation right now doesn't have the money. They're dipping into their savings already for day-to-day living. And so we're seeing a downward trend on laser vision correction nationally, down 50% over the last 2 years because of it. And I think once the economy is better and it kicks up, I think we're going to see a return to having more patients interested because they're going to have the money. That's my opinion. Andrew, what do you think?
Yeah, I think so. I think the economy plays a big role. I also think that maybe social media has played a little bit of a role too. I think the fact that most of the Gen Zers out there are on TikTok for a lot of their education, and so they're getting their education on maybe from a viral video of a very unhappy LASIK case person who was very unhappy and posted online horrible things about the procedure, whereas 99.9% of the people who've had it are happy and aren't posting anything. But because of the social media and the noise that comes with it, and all of the ability to amplify the voice of the small, they see that. And I think what's going on now is that the Gen Zers have more fear. If you were to ask me, I think they have more fear and more anxiety over the procedure because of things that they see online. Whereas the older group, like if you think back 15 years ago when we were doing this, nobody was, you could see a video of LASIK online, and that might be disgusting to people, and they might say, "Oh, I wish I hadn't looked at it," but they wouldn't have watched somebody freaking out about a negative outcome, okay, which is going to stick in their head. So I think that there is a very distinct difference. So, John, I think that the Gen Zers are a little bit different than they once were.
Yeah, Sonny, this is a podcast on fear. The financial aspect is not where we're going with this. I do think I'm with Andy. I think there is just, an inherent apprehension. Andy said at the outset, anxiety, fear, tends to kind of permeate. It's throughout the community. I don't think we're truly identifying as much anxiety that's really out there. I mean, we all have kids. I could tell you that, yeah, I mean, anxiety, getting into the right school, being in the right friend group. There's anxiety to all of it. I don't think it's unique to their generation, but there is something a little different with the younger groups. I do think, and I don't know if I can put my finger on that at all, but I do think there's a fear aspect to this.
Well, I think there's more anxiety overall, right? Even not related to this. I think they have greater anxiety in all realms of their lives, quite honestly. It's just one of them.
I think it's got to do with these waves, these headphones, or something that, I used to think it was diet soda. Now I'm starting to think it's the waves, from the AirPods or something that's happening that we don't realize, that's creating crazy anxiety.
Yeah. I had this image of Andy walk around his house with like a tinfoil hat on.
That's right. I didn't do it
awesome.
Now. That's what it is. The Grateful Dead playing in the back, Charlie running wild. That's right. Keep himself nice and relaxed. That's how you do it.
Exactly.
With the Malta Pacino in his left hand. That's really
no anxiety there. No anxiety there.
All right. So to make it a little bit more relatable, I'm going to just tell everybody on the podcast, I myself am about to undergo a procedure. No, it's not a hemorrhoidectomy, and no, nor is it genital enlargement or anything like that. It's a hip replacement. So I'm, and it's going to happen in 36 hours. And I was frightened, before when I first thought about all of this. And then I actually started to, talk to the doctor, did more research, read all about it. And I'm like ready to go. I'm like excited to do it because I know I'm going to be fine, and I know that everything's going to work out. So I keep coming back to this thing where we need to somehow educate patients. So people come in for consults, they're kind of in and out fast. And we give them a bunch of information, but it's like, it's superficial, really. When you think about it, it's superficial information. We talk about some risks because we feel like we have to. So, but we probably don't talk enough about, what is actually going to happen and how safe it actually is. Okay. And how well everybody does. I think those are things that we don't probably hit on. I think we don't hit on enough during a consultation. Whereas, I think especially the optometrists that, we're doing these exams and everybody's doing exams and we got to hit on this. Okay, you can have dry eye, you can have glare. It's all going to be temporary. Yes, this can happen. This can happen. This can happen. Okay, here's the counselor. We have to be more, kind of forceful in talking about all the great things that are going to happen. how it's going to happen and make sure that they understand the process really well.
Andy, can you talk about, if you feel comfortable, kind of go through your experience in your orthopedic surgeon's office versus the kind of experience that you provide your patients in your office, and where you think you guys had similarities, where you think there were differences, and if they mattered. Like, did they talk about all the upsides and then diminish the downsides, or
yes,
they did?
Yeah, they talked about all the upsides and barely talked about any negatives. The negatives were on the consent form that I have. But most of it was positive. And hey, here's your X-ray. We got to fix this. You're going to be fine. Don't worry about it. Couple weeks, whatever. But I also found profound differences in just like the lobby and the patient experience that we provide. So I think all of us probably do provide a better patient experience overall, but they're more forthright with the positives in my mind, as opposed to some of us where we have to talk about some of the risks.
How many consults did you do, Andy? How many different providers did you see before settling on the provider and knowing the procedure that you wanted? I mean, are you able to share that? Or
yeah, I mean, I probably saw 3 or 4 different providers at least. I went to an expert up in New York. I saw a couple different experts in the DC Metro and Virginia. So, and then I picked the one that I felt most confident in, best rapport, and I just the feeling that they cared most about me. I think that's who I'm going with. So,
and what can you do? Is there a particular? I mean, I think this might be difficult to say a phrase, or what was it that allowed you to relate to the surgeon? Was there something in particular? Did he say something, or she say something? What was it that allowed you to feel that this is somebody who cared about you as the patient? What was it? I mean,
asking me questions about myself, what I do, talking to me about, eye surgery, spending a few moments with me about just general stuff, showing an interest in who I am as a person and what my activities are and how this is going to impact my life. That more, as opposed to just bang, 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 you need a hip replacement, see you later. Here's my fellow. He's going to talk to you about, the blah, blah, blah. I didn't like that approach. I like the more, personalized care.
Had he done 100,000 hip replacements?
Yeah, but I think you appreciate that, because that's the kind of experience you provide your patients, right, Andy?
Totally.
So you wanted to be consistent to what you provide.
Exactly.
Quite honestly.
Similar.
But I still would say he could have been the most personable individual because his reception area was empty, and you're the only person that he could have been given time to. So you could have gotten that as well. And I mean, I'm joking, obviously. The point is, there's certain assumptions that are already made here that the individual is capable, has enough experience, knows how to manage your particular case, in addition to being relatable, right?
Right. Exactly. Yeah. Perfect. Yeah, exactly. That's how it is. I mean, we're not going for consultations with people who we don't feel are competent. And, part of our problem as refractive surgeons is that we have, we're all sort of patient-centered, in our care, whereas some of our competition out there is not so patient-centered and are more sort of in the corporate box type places that are more discount-oriented, and patients are somewhat drawn to those because of a price point, and sadly, they don't have the same kind of patient experience. Sometimes they don't have the same kind of outcome that we could provide. But that's where we are. I think sometimes our industry gets a bad rap because of that, because of those types of providers, and everybody thinks that we're sort of like shysters out there, oh, you're a LASIK surgeon, what do you charge? $5.99 or, I mean,
Yeah.
that kind of thing.
Do you guys know Simon Sinek or seen Simon Sinek on the TED Talks? You guys ever see his talk? Oh my God, he's amazing. And he talks about how great leaders lead. And he talks about your why, like why you do what you do. And I want to just kind of piggyback off your comment about, the corporate charging less money. Why we do what we do, the three of us, is to make patients happy, right? Help them to see better. How we do it is by providing laser vision correction services, or by doing lens-based procedures, or by turning them away. That's how we can make patients happy as well, right? Whereas the corporates, the center of their why is money, right? That's why they're there. They're the MBAs, they're the private equity guys, and their whole goal is to make money. And then how they do it is by providing the services they provide. So they're trying to provide the same services we provide, but our why is completely different, which is why the patient experience is completely different. And why we have so much experience, why patients love you, Andy, when they come in and meet with you, or love you, Jonathan, and hopefully love me when they come in and meet with me and my team, because we clearly care. And you can't make people care. They either do or they don't, right? And I think when they sense that you care, to your point, Andy, that helps them with their fear factor. They're coming in, they see the great technology, and they see how we treat them. And I think that helps to address some of their concerns, maybe not all their concerns, but some of their concerns. And then it's a matter of, okay, well, I like this guy or this team to do what I need to do to see better. So I highly recommend you guys watch it. It's about a 20-minute TED Talk. Simon Sinek, Sinek. It's wonderful.
Will do.
So that's it. I think that might be a great time to kind of sign us off for our third episode. But this whole process, right, is for us to understand fear. It isn't necessarily a sign that you're making bad decisions. It really is for us to understand, that we can reduce fear for our patients and those who are listening. That it's achieved through really improving education. So we touched on that. You got to be able to educate your patient base. And then by the time they come in, there's got to be some measure of relatability. You got to be able to sit down and communicate and talk. And then I would imagine also a big part of it is
I lost John.
Yeah, he froze up a little bit. While we're waiting for him to come back, one of the things I want to talk about is just this Venn diagram the patients have about their comfort zone, which is there's a larger safety zone and a smaller comfort zone within that safety zone. I think people in general, not just with LASIK eye surgery, but people in general like to stay within their comfort zone and not expand out, even though they're still in a safety zone. They need to just kind of push out their comfort zone in order to but still stay safe. I think with what we offer them, as long as we deem them to be a good candidate, we're letting them know, hey, you might be getting a little bit out of your comfort zone, but you're still safe. You're still going to have a great outcome. You're still going to, this is going to be great for you because we're going to make sure we do our best to help you see the best that you can see. And you're still within the safety zone. So how do we get that across, I think, to your point, to patients who are really anxious and there's just, the comfort zone is just small, but their safety zone is this big.
I love that.
That's a good one. Sorry, I'm back, guys. There you go. As I said.
Well, you're back. Yeah. And in terms of, I think being a great surgeon is not just being so skilled and technical and meticulous, but it's also being able to, connect and educate. So I think that's what we, that's sort of a bottom line for this discussion. And for those of you who are out there listening to us, I feel like if you're interested in the procedure, you should at least, understand that it's not a risky procedure. These are not risky procedures. None of them are RLE for having your lens removed, and then being able to put implants in for distance and near. This is standard procedure cataract surgery that's been around for 50 years. But it's been refined to such a degree that now it can be done in a matter of minutes, incredibly safely. And then laser vision correction and SMILE and these procedures are also very, very safe and very, very effective in the right hands. And I know, I just think that it's that thing that I think I might have mentioned to you guys once before, is that, if you ask somebody what's safer, flying to DC from New York or driving to DC from New York, almost everybody would probably tell you driving. Okay. But it's clearly not. Okay. It's clearly not. And the reason it's not is because, obviously is obvious, because there's car accidents, et cetera. But people believe that it's safer because they feel like they're in control. All right. And I think there's this fear of loss of control when you're in a prone position, laying down, your eyes are propped open. There's a fear of loss of control. And I think that with the pervasiveness of anxiety in today's world, some people are just afraid to take that step. And we'll continue to do whatever we can do, try to educate people in advance.
And fear is natural and normal. I tell patients, I deal with nervous people all day long because of what we do. It's all day, every day. We deal with people who are very nervous and very fearful. And if fear is not a sign that you're making a wrong decision, it's really a sign that you're making an important one. And our goal isn't to eliminate it completely. It's still going to be there. But it's really to replace the fear of the unknown with the understanding, with perspective and confidence, to move forward with the big decision, that they've been educated to that level where they're like, yeah, this is the right thing for me. I'm glad I explored it.
Perfect.
Well said. Well said.
Awesome. Well, is that a wrap, guys?
It's a wrap.
Maybe just have like a quick sign off. Thanks for joining us for the third.
Yeah.
Andrew.
Okay. Yeah. Thanks for joining us for our third episode of Wise Eyes, guys. We're enjoying doing this. Hopefully you're enjoying listening, and you'll be tuning in to future podcasts of ours.
All right, guys. Till the next time. Looking forward to it.
Cheers.
Next time.
All right, take care.